Welcome, everybody. I'm Joyce Logan, and I'm on the board of DAPS, and it's my privilege to introduce our speaker today. We're going to have Dr. Fulbright. He's a clinical psychologist specializing in clinical neuropsychology. Dr. Fulbright has an extensive experience in evaluation and rehabilitation of traumatic brain injury, Parkinson's disease, stroke, multiple sclerosis, toxic exposures, and development disorders. Parkinson's disease and other movement disorders have become an area of particular interest and expertise over his past 13 years as he has worked with several neurologists who are fellowshipped, trained specialists in movement disorders. Dr. Fulbright currently oversees the Fulbright Neuropsychology in Dallas. Fulbright Neuropsychology is a private neuropsychology clinic specializing in cognitive rehab therapy. So welcome, Dr. Fulbright.
Thank you. I'm trying to figure out how to work the mechanisms of all this with my timer and standing by the altar. I'm not worthy. I looked at this and said, oh man, this is impressive. It's intimidating. Can you hear me? How about now? Can you hear me better? Okay. Anyway, I walked in here and went, oh man, I'm not worthy. This is not good. But I don't claim any special powers or anything. So what I wanted to do is talk to you guys about Parkinson's and the cognitive aspects of this, which is what my involvement in this was. About 20 years ago, a neurologist who was a new movement disorder specialist came to town and somehow thought I knew something about it, which I didn't. But she said, you will. And so I started doing it and started learning a lot. I learned a lot from her, and I learned a lot just in the course of doing this. And of course, my patients were my absolute best teachers, as is always the case. My background in terms of illness type, neurological illness, was predominantly in dementia. Alzheimer's I did my dissertation in it, and I would test people. We would look at various, what type of dementia, and there are various causes of it, which we'll talk about here in a second. So Parkinson's comes along, and the doctor is referring to me and say, well, are they demented? And I'd say, well, they got the cognitive stuff that goes on with Parkinson's. I wouldn't exactly call it dementia. And dementia is a bigger deal. So it's a much bigger issue. Let me see if I'm getting this. Here we go. So let me make sure I got it. Here we are. So just to start off with that, people will come to me and say, well, do I have dementia? Or they'll ask questions like, well, is dementia the same? Is dementia Alzheimer's disease? Or is Alzheimer's disease dementia? And it's like, well, okay, we need to let's start from scratch here. Dementia is the overall description of, it's an overall category under which a lot of diseases or a lot of types of dementia fall. What you call dementia, especially with Parkinson's, because it's not a primary dementing disorder. Alzheimer's is, dementia with Lewy bodies is, Pick's disease, which is another form of dementia. Those are progressive degenerative of the cortex, the gray matter of the brain. And the thinking parts of the brain. Parkinson's secondarily affects cognitive functioning for the most part. Some people have more involvement, other people have surprisingly little. And you'll see people who physically have got significant limitations, and at the same time, cognitively, they're pretty much there. So, it really varies from person to person, but generally, folks with Parkinson's have a different pattern that's real distinct. General levels of dementia versus cognitive impairment versus that stuff you get with Parkinson's. The current terms are, dementia means a significantly impaired functioning across multiple areas of thinking, and you also have a global decline in just day-to-day functioning. Now, cognitive impairment that you wouldn't quite want to call dementia, some people call it mild cognitive impairment, which like it's a diagnosis. I don't like that because it doesn't give you an idea of the cause. You can have mild cognitive impairment for all sorts of reasons. But when we talk about cognitive impairment, that means there's limited but measurable deficits in thinking abilities that we measure with testing. What they call mild cognitive impairment, and I'm still not big on this term, It means cognitive impairment you will find on testing, yet the person continues to function pretty well. And you'll see this sometimes, and you'll test people who you go, oh, yeah, that's worse than I expected, but they're still out there in the world functioning surprisingly well. So that's the mild cognitive impairment description. Now, let me see if I can get this working here. I hate it when the guy can't work his own AV. Oh, no, there it is. So where I want to go today is, well, hang on. Come on. I hate it when the speaker does this. Okay, so which way am I going here? All right. Come on. There we go. Okay, so what I want to cover today is talking about the types of cognitive functions, thinking abilities, that Parkinson's tends to hit on, and really differentiate that from other types of disorders that have a bigger, typically more profound impact on thinking abilities. Now, the word cognitive just means thinking. When we're talking about cognitive, it means your verbal knowledge. It means your attention, your processing speed, your ability to learn and hold on to new information. It has to do with language skills, spatial skills, putting stuff together, figuring out how to navigate around here. And we also look at sensory motor functioning and also executive functioning. Executive functioning is that part of your brain that reminds you to do things and keeps you on track and monitors what's going on, reads the room and says, okay, everybody's falling asleep, I better better pep it up here. So you can't measure that with testing, because we're in the testing room saying, okay, do this, do that, stop, start, you're right or wrong, and we go on. So we can't measure that with tests. We do measure that with people's self-report and with questionnaire type measures that they tell us, here's what goes on in everyday life and here's how often it goes on in terms of absent-minded errors, which is really a lot of how executive function works. We'll talk about how, must have hit the button again. I want to talk about how memory is affected in Parkinson's, but it's a different pattern than what you see in Alzheimer's. And the memory impairment really is an issue of attention, because Parkinson's tends to hit attention harder than memory, but if you can't get things into attention or through the attentional porthole, you can't get them into memory. So that's a factor that we see on testing. The cognitive impairment we see in Parkinson's folks is generally much less widespread than what you see in patients with dementia. Now, over time, yeah, cognitive functioning is probably going to progress and get worse, but it's not the same pattern in the majority of cases. Neuropsychological testing, this is what I do. I'm a neuropsychologist, which means I'm a psychologist, trained as a clinical psychologist, did additional training in terms of testing. Now, we all learn how to do psychological testing in school, but this is neuropsychological testing, where we're looking at people's brain function in terms of their thinking abilities. So we do a much more detailed assessment of the things we've talked about, attention, concentration, processing speed, et cetera. And we know how, and that's in the context of different types of brain conditions. So we'll test somebody and be able to determine this is a pattern looks like Alzheimer's, or here's how this injury or this illness is affecting their functioning. And that's really the key reason to do the testing. I'll talk a little bit about medication. It can be an important tool for addressing some of the cognitive decline you get with Parkinson's. And in cognitive intervention, I used to say, man, wouldn't it be great if we could do cognitive rehabilitation with Parkinson folks, because they're able to learn, they're able to hold on to things, they're able to make use of this data. I mean, look at voice training, and look at the big program. You can recalibrate the brain in Parkinson's and do it pretty effectively to get around voice and movement. And I think with cognitive function, you can do some of that as well. Attention is trainable. And if you got an attention problem that's a bigger part of Parkinson's, guess what? It's trainable. I used to say, wouldn't it be nice? Literature I reviewed for the talk today, just to get caught up, says they're doing some of this, and they're actually finding good results. Don't know if Medicare will pay, but that is happening, which is good to know. And it'd be good if I can make this thing advance. Okay, come on. This is, okay. So types of dementia. You know, when people come to my office and, you know, they'll say, it's usually broad, vague definitions or confusion about, do I have dementia, do I have Alzheimer's, is dementia part of Alzheimer's, or it's a kind of a, people aren't real clear about it. Dementia is an overall category, and it can be caused by lots of things. Alzheimer's disease affects the gray matter in the brain. It affects the part of the temporal lobes that run memory, the hippocampus, and it really gets into the parietal lobes. So you go looking for words, you go looking for faces and people. Your library is missing some, it misses some volumes in there. It has a, you know, Alzheimer's is a global decline, and it causes a significant amount of loss in a person's functional capacity, their memory, then remote memory goes, they don't know who's who, they get people mixed up. They think, you know, like Mr. Iverson was saying, you know, they think you're the spouse and they're your kid or that sort of thing. It's a profoundly, you know, disabling condition, and people generally lose their identity. I mean, to put it bluntly. Vascular dementia is when you have a lot of small vessel disease in your head, where we all have capillaries shut down in our brain as we get older, but this is when you have more of that, and it's more advanced. And what you see with that is that people who are, they're slower, but they can function. They can do things, but they get overloaded fairly quick. But they know who they are, they know who you are, and they're more tuned in. There's metabolic dementias. Let's say you get a urinary tract infection or you have a metabolic problem. You can show up and look like you've got some significant cognitive problems. Urinary tract infections are the number one reason when people show up, older folks show up confused, particularly women, in the ER and they're confused looking, they better be looking for a UTI first because they don't pick up on it and it gets in their head. I mean, they get sick with it and don't realize it and they look demented. Usually they do, but always push for that if you see that. Now, there's another category called frontotemporal dementia or degeneration. One, Pick's disease is really what they used to call this, and it's a kind of it's a different mechanism than Alzheimer's. The cell pathology is different, and they're called Pick's bodies in the brain. It usually hits one side or the other. It'll hit the behavioral side, which is the right hemisphere of the brain, or it hits the left side of the brain where language is. My mother had a primary progressive aphasia type, and you could see her language dropping off over time, but she was fully aware of what was going on, had good judgment, could still, you know, function pretty independently, needed a little bit of help later on, but she could do that. The behavioral type, generally you see a load of apathy. I mean, a person just sits, they don't have good judgment, they're not processing what's going on, or they think everything's fine and they don't think they have a problem, which is kind of what the right hemisphere injury does. Lewy body dementia is something you hear a lot about with Parkinson's. People will have Lewy body and dementia, and they look like they have Parkinson's because you have the same motor symptoms, but not as much. And when you're looking at doing DBS, for example, or when you're looking at this person having hallucinations, it's a different, you have to separate that out from the Parkinson's. They coexist a lot, and you can have Lewy body and Alzheimer's or vascular dementia. These things can coexist. But you want to be able to identify that. If you have Parkinson's and you're up on you go up on your meds a little over your threshold of, you know, normal for you, you can start hallucinating, and that's not the same as a Lewy body dementia. When that occurs, it's a medication effect. It's not necessarily Lewy body. Lewy body is when people have a lot of this frontotemporal degeneration type symptoms, but they start hallucinating and seeing people hanging around. They're not threatening. They usually just kind of hang around the kitchen. Or, you know, a friend of mine, her dad had gypsies playing cards at the kitchen table at night. And another friend of mine, her dad had dwarves running around the house. And he knew. I mean, they said, I'm hallucinating. These are dwarves. They're not there, but I see them. Isn't that weird? That's pretty classic Lewy body symptoms where they see it, they understand it, and they go, okay, this is not real. And it gets mistaken for Parkinson's because of the motor symptoms. There's another type of dementia, pseudo-dementia, due to depression. I will have families bring a person in, and they'll say, you know, mom's, I think, losing it. And you talk to the person, they say, no, I'm depressed. And we test them, and they look perfectly fine on testing, which is a really cool thing about neuropsych testing, because they look bad, but you test them, and the circuits are all hooked up just fine. They're depressed. So, this is where my motto always is, well, if we knew what it was, we wouldn't need to do testing. So I guess that's kind of obvious. Now, let's talk about Parkinson's disease. This term dementia is worrisome because of who calls that what. The majority of patients with Parkinson's don't develop this global dementia that looks like Alzheimer's. Again, Parkinson's is affecting circuits deeper in the brain. It's not hitting the primary memory centers and the primary library of your brain. It's typically not hitting the frontal lobes where your behavioral regulation happens. It hits motor function. Now, with motor function, it's also going to hit attention because they're all driven by the same neurochemical dopamine. So your activation level, if your dopamine-producing cells are thinning out, when you hit the threshold point, you are going to have some cognitive slowing. You move slower, you may think slower. You've obviously got the motor involvement, but it's not right. It's not involving a significant atrophy of your gray matter, which is where the thinking is. The studies, people with Parkinson's, particularly as the physical symptoms progress, generally show some degree of cognitive impairment associated with it. Now, we look at people, let's say a 75-year-old person comes in with it, we do testing. We just don't say, yeah, you look like it's not so good. We look at this person compared to norms or comparison bases for how does a 75-year-old look? How close to the middle are they? Are they far out? Are they in the middle? On all these variables that we measure. So it's kind of like a blood test where you have all these things you measure. You've got the numbers, and it's sort of is it high, low, or not? And that's kind of the way we do that with neuropsych testing. And so with Parkinson's folks, yeah, you're going to see some changes. To equate that with an Alzheimer-type dementia is just plain inaccurate. It's not right, not accurate. The studies where they talk about dementia they say that somewhere between 11 and 75% of Parkinson's patients develop some form of dementia. Now, the problem with that is in the studies, what do they call dementia? They may give two brief tests, and if they do bad on one, they call it dementia. They may say, no, this is mild cognitive impairment. We did a much broader range of testing, and they look pretty good, but these are the areas where they're having trouble. The way they define dementia across these studies tends to be real focused on who did the study and how, if someone has a cognitive problem, they call it dementia. I don't agree with that. I think that's inaccurate again. The impact of age on cognitive changes with Parkinson's, I think it's unclear. We don't see a real distinct correlation other than normal aging effects. There's plenty of older folks in their 80s who come in. I test them, and they're not very involved, but they've got Parkinson's. They can look just fine, or they can show some of the typical problems. When I see patients in my office with Parkinson's, and I have for about 20-plus years, and I've seen a lot of them, we see a lot fewer of these folks with dementia than we do with some circumscribed, limited cognitive impairment. One of the reasons we test people, too, is candidacy for deep brain stimulation. If they have dementia going on, which means a broader amount of impairment, they're not good candidates for DBS, because it can sometimes make them it's predictable that they'll take a turn for the worse cognitively. So that's, you see a lot of folks that have impairment, but they're not demented, and that's kind of where my perspective is. Okay. Well, okay, I think this thing may just be slow. There it is. So Parkinson's usually starts with motor symptoms, obviously, and then cognitive symptoms, kind of bring up the rear. It can be pretty subtle. The cognitive things that you see in Parkinson's tends to be executive functioning, which is kind of that oversight of the supervisor of your brain that calls the shots, tells you what you're supposed to do. It's like the conductor in an orchestra. You got all these parts working, but you got this other thing directing you as to what you're supposed to do. And that's really a function of attention, because you can not only do what you're doing when you're paying attention to it, but you have more attention that observes you doing the thing you're doing and kind of gives you commentary as you go. So with Parkinson folks, we tend to see deficits in executive functioning, uh, and we also see problems with attention, concentration, and usually slower reaction time. You'll see deficits in attention on testing that are pretty consistent. Think about it. Dopamine is the neurotransmitter that's affected with Parkinson's. Dopamine is critical to your arousal level. People with ADHD have too little dopamine. So you give them stimulants and they wake up and do better. So if you're having a dopamine deficiency, no big surprise, you're moving slower, your thinking may be slower, your arousal level, your alertness level may be somewhat lower. And that begins to sink in later. Usually it's just the symptoms at first, the motor symptoms. What we see on testing is that folks show some problems with new learning and memory, but it is absolutely nothing like what you see in Alzheimer's disease. So again, back to, do I have Alzheimer's disease? It's like, no, you have Parkinson's. It's a different process and a different picture. I think I just did. Yeah, I've already gone there, okay. Why am I going backwards? I'm so sorry, this thing is not, I hate it when the AV, the guy giving the talk can't manage his AV material. Okay, this kind of covers the same thing. Just the research on that people with Parkinson's, one study shows about 25 to 38% of people with Parkinson's have mild cognitive impairment. One study, says 17 to 53% of people who were treated and untreated folks with Parkinson's, they show the same kind of configuration of strengths and weaknesses in their thinking. The main things we see, deficits in our attention, processing speed, memory storage for detailed information, meaning you've got to stop and organize it using executive function to go, that's a lot of details, I better start, sorting things out in my head while I'm learning them. Abstract reasoning, you'll see an odd and predictable dip on one particular test we give, and then executive functioning, which we've talked about being the kind of supervisor of the brain. Like I said, they're a lot milder than what you see in Parkinson's. There we go. So when we look at people with Parkinson's, these are the main things you'll see. Nonverbal intelligence, which is generally hands-on problem solving, spatial skills, attention, processing speed. Memory is not bad, but when you hit them with a whole lot of stuff where they have to stack a lot of information, you see some dropout there, but not like you do with Alzheimer's. And abstract reasoning is variable. It's a little wobbly. With Alzheimer's, it's a much bigger pattern of deficits like we're seeing here. I mean, with memory testing, for example, you have them learn the list of words 5 times over. They don't get very much. You come back a little later, so you tell me that list again. They're going, what list? And it's a very distinct, different pattern. They will throw in words that were never given because they think, well, let me think of the words, and they can't discriminate between what they're thinking and what was actually given. Parkinson folks don't do that. It's a very distinct difference. So on testing, we can see this is a different pattern. And they generally have no awareness of their deficits. Folks with Alzheimer's truly think things are okay. I mean, I'd ask them, why are you here? They say, because they brought me, talking to the family. Are things going okay? Yeah, things are great. What about what they're saying? I don't know what they're talking about. And that's really kind of what you see in pretty early stage Alzheimer's. And people look great, and we test them, it's like, oh man, I didn't see that coming. So, there we go. So what testing is, let me explain that, because we're going to go through some data looking at how Parkinson folks do. And let me check my time here. Let's see. I'm doing all right, okay. Just want to make sure I'm not running over my time. I don't know how many of you guys have had neuropsychological testing or your person has with you. What this is, these are psychological tests, and psychologists have been going around measuring human behavior, whether it's, emotional stuff or cognitive functioning. We started off measuring physiology back in the 1800s, and that's kind of where we got our start. Over time, we expanded into other stuff, but what we do is measure behavior. It's a fuzzy concept. It's a fuzzy entity to try to measure. But with testing, we can do that. We have standardized procedures, meaning we're going to do a memory test. It's the same list of words given the same exact way every time. And then we can compare you to and how you did on it compared to a whole group of people that have had the exact same procedure. So we don't just eyeball you and you got 2 out of 5 words. We go, oh, they're impaired. It's much more detailed than that. So we look at a whole wide range of things with a number of tests that for each area that we look at. I mean, there's 3 or 4 tests we look at with attention, 3 or 4 tests with memory. And you can kind of tease out how much is memory, how much is attention, how much is processing speed, how much is language or spatial deficits contributing to memory, for example. And we have to kind of tease that out and look through the data and find what's the thing that keeps recurring through here that explains how they're doing. Norms, I think I mentioned earlier, you look at age, you can have for age alone, age and education, some age, education, and gender, depending on the test and how good the norms are for that. But you get a profile of strengths and weaknesses. So somebody comes in and the family's going, this is a different person. I don't know who they are. They're forgetting everything. They keep telling stuff and they forget it all the time. Well, let's look at what's going on. Is it memory? Is it attention? Is it they're being ornery? I mean, what is it? And so the testing lets us see, are they holding up pretty well here? Or they have dropouts here that explain that. And so we try to take the test results and apply it very directly to the questions people bring in, whether it's family members or the patient. Do they have Alzheimer's? Big question. It's like, the thing I love about working with Parkinson folks, the vast majority of the times, this is not Alzheimer's. Calm down. This is a different thing. This is something you can manage way better. And there's things to help. So, come on. All right. So these are the things we measure. I've explained that. I don't need to belabor that. And I can't believe it. All right. There we go. So, what do we use testing for? Doctor refers somebody to me for neuropsych testing. Diagnostics, is this an Alzheimer pattern? Is this more of a vascular-looking pattern? Is it dementia at all? All the things we talked about, the different types of things that could cause that. What about treatment decision-making? Do we need to put them on memory medication? We could have a pretty good picture of that. If somebody's really awful with memory, yeah, get them on memory meds. If it's not memory, it's mainly attention, memory meds probably won't help. With DBS, that's certainly a big treatment decision-making question, because again, if somebody's got a lot of impairment, they're probably not a good candidate. What about tracking? I know the doctor that I worked a lot with would send me case and say, we just got diagnosed, we think there's some kind of cognitive involvement going on. Let's test them now and have a baseline that we can compare against later as time goes on, which can be helpful because, the whole business with assessing a family member or a patient, particularly a family member, or if you are the patient, is being able to put it in perspective. How bad is it? If you're off a little, you don't know if that means you're losing your mind or if you're off a little. And you're good in a lot of areas, you may be off in some. So giving perspective, I think, is a real key element of what gets accomplished with testing, certainly for the family and for the patient. Yeah. I'm sorry? You can go ahead. I don't know the numbers on that. I've seen, she said the younger you're diagnosed, the symptoms progress faster. I think anecdotally, I think there's something to that. There's certainly older folks that get diagnosed late in life and it doesn't progress real far. Younger folks have a longer time to go and the symptoms, it's hard to know, but I don't know the data on that, so I would rather beg off on that. I think anecdotally that's probably right, but it's not always, you can't always, it's not the strongest effect I've ever seen. It's not like you got this, you're going there. I've seen that enough to know that to be cautious about answering one way or the other on that. So, what we want to get at is what's different with this person cognitively? How are they different? Let's define what's causing these differences that you're seeing in this person or in yourself. How widespread is it? Is it just a few things, or is it a whole lot of things that's off? How bad is it? Is it like notably severe? And does it correlate with what they're doing in real life? I have a friend with Parkinson's, and my office did testing. I didn't do it because he's my closest friend, but somebody else in my office did, and he looked worse than expected. He's still doing great. He's still functioning just fine, but his testing looked lower than I would expect. How about that? It doesn't always tell you everything. You have to look at the whole picture, not just numbers. And then what do we do about it? How can you help this person? Are they really having memory issues that need, memory meds? Are there other things they can do? They have a sleep disorder that's interfering with thinking. I mean, you look through all these areas, and so you look at the things that might be contributing to this. Are there medications that may be causing problems that aren't the Parkinson meds? And, one of the things, too, is families, caregivers can think, well, we have to take care of them all the time. A lot of Parkinson folks are very independent, and they can still function just fine. They may need some help, but the question is where. I mean, for me, it's like, when do you stay out of their hair versus when do you say, look, this is where you really need help. And I think the testing can help you see that in terms of, this person is performing in these areas the way they should be. But, in real life, there's some areas where things get wobbly. Here's where they need help, and that's probably going to keep the other things from being as wobbly. Like Mr. Iverson was saying earlier, one of the things you need is help. The question is how much and where. Where is it strategic and least invasive? I think that's important. And, things like driving, finances. Should they be managing their own medication? Can they be living independently? The driving, we can come up with, it's, I try to be cautious about that, but you get enough data to go, it's not looking great. You should have a formal driving evaluation, not at the DPS, but at a rehab hospital where they can really look at this. Medication management. If this person's confused, are they going to be able to keep track of their meds? Big deal. It's a really big deal. So, the testing can help us get some data there. So, enough about one other thing, how often retest. If you have a neuropsychologist who says you got to come back every year, once a year, they're talking, that's good for them, it's not good for you. What my theory has always been, you test as the symptoms dictate. As soon as the test results you have no longer explain what's going on with this person in the ways that it matched up, then that's when you think about it. Are they worse? I mean, I'm seeing a lot of changes. Let's reevaluate them then. Doing it once a year is good for your checkbook, but it's my checkbook, but I don't think it's necessary or ethical. Also, Medicare allows only one neuropsych eval per year, per calendar year. So you could technically have one in December and another one in January, but such as bureaucracy. Now, what I want to do is get to some data and try to show you if I can get my projector to do this. Okay. I think we've already covered this, that uncomplicated Parkinson's shows pretty good performance in those areas. You usually see impairment in, again, speeded tasks, hands-on things, not due to the tremor, but because of it's novel and you have to kind of thinking on your feet with nonverbal type tasks, puzzles and, reasoning tasks. Memory gets affected. We'll talk about that. But, I'm sorry, you have preservation of the verbal intelligence, memory, language, academic skills. It must have skipped on me here. I'm sorry. So these are the areas that tend to get hit. Like I said, it's the nonverbal stuff. It's attention, which is probably the biggest thing. When you think this person's not learning or not remembering or they're not responding, they may not be paying attention. And if you get their attention, like, hey, all hands on deck, I need to tell you something. Like, oh, okay. They can shift, and once they shift, they're probably with you a lot better than if you're running out the door saying, I'm going to the store, see you later, and they didn't shift their attention to go, oh, I heard that. Well, I told you that. Don't you remember? I think that happens in every marriage. but, but it happens more in that sense. And the main thing is you have to be more deliberate about getting a person's attention. And this is just, I'm going off on a side rant. Reasoning and problem solving. Conceptually, a lot of times folks with Parkinson's are doing fine. There are some things, and there's a particular test, and I don't know why this is, but it's this Mariana Trench, among other abilities, are looking pretty good. There's this drop-off, and it's an abstract reasoning kind of hypothesis-forming test. You have to test out a hypothesis. Is this what's going on in this series of pictures? You're telling me right or wrong with my responses. It's like a logical pattern that you have to figure out what's the pattern of this stimuli we're showing them. Parkinson folks tend to have trouble on that, but they do better on other things that require similar but different type of skills. Academic, I shouldn't say academic skills, that's wrong. Motor skills, you'll see some impairment. Academic shouldn't be there, I'm sorry. Come on. All right, so let's talk about, I had an extremely ambitious student. I've had students from UTD that were undergrads. Now, they couldn't do any service in my practice because you have to be licensed to do that kind of thing, treating patients. But they could come and observe. And I saw they were from the neuroscience program, psychology program, some of the brightest people I've ever met. The one that helped with this, I told her, when she left, I said, don't forget us little people when you get there because you're going there. She went to UT Southwestern, got her PhD in short order, went to the Mayo Clinic and did her internship there, and then ended up at the Cleveland Clinic. And I see her at conferences always toting around presentations. So when she was an undergrad, she said, why don't we put all the data together and take a look at this? So we pulled all our Parkinson patients up, and she put this data together. We had 55 patients. It was Parkinson's only, no frontotemporal dementia, no Lewy body, just that, and as close as we could get. The average age was 69 years, went from about 80 to 50, if you went either side. Education level was about 3 years of college, and about 70% male, about 30% female. So this is the group we looked at. And the testing, well, hang on. This thing is really, all right, that's just crazy. Come on, there we go. So on this, the laser thing isn't working. So I don't know if you can see, there's kind of a blue band in the middle. I don't know if that's visible or not. This is on IQ testing. 100 is average. And 90 would, below 90 would be low average, above 110 would be high average. So with Parkinson's folks, their verbal IQs are coming out perfectly normal. They're not losing information. They're not having trouble thinking abstractly from a verbal standpoint. How are a ship and a plane alike, something like that. Their transportation, that kind of a thing. They're not having any trouble with that. Alzheimer folks, who was president during the Civil War, and I'm talking about history professors will go, I should know that, and they can't pull it up. That's a difference. But nonverbal stuff is lower. It's not as bad as what Alzheimer folks do, but they have more trouble. And overall IQ, they're coming out in the average range, even with the problems they have. So right there is a significant, characteristic is that the nonverbal stuff suffers, the verbal stuff doesn't suffer. Well, here we go again. All right. This is a test of attention. 20 minutes, I call it the proof of hell test because it's so boring that, you're going, there is hell. And when I get there, they're going to have this waiting for me. It's the most boring 20 minutes of your life. You're wishing for death at the end of it because it's so boring. You have to sit in front of the computer and hit the button when you hear or see a 1. Don't hit it when you hear or see a 2. 20 minutes of that. It's bad. Parkinson folks are able to hit the button when they're supposed to. They're pretty good at their stamina, staying a pretty steady level of performance, so the test is good. But you notice that the auditory vigilance means are you hitting it when you're supposed to? That's lower. And the key thing there is that on this test, it's not about do you pay better attention to what you hear or see. But if you can't go in back and forth between, they say a 1, flash a 2, say a 2, flash a 1, and you can't switch back and forth, your brain goes, let's simplify this, and goes to one aspect. So when they say it, I'll hit it. Or when they flash on the screen, I'll hit it, but I can't do the back and forth. That's what we get with these folks on this test, where you've got to have this controlled kind of response. They go, I can't do the switching. So that's a real common finding there. But you notice it's not at the bottom of the heap by any means. These tests, one's a listening test, one you have to filter out distraction. And Parkinson folks in our group did great. The Seashore Rhythm Test, this is 30 rhythms, pairs of rhythms they have to say same or different. They're performing perfectly normally. Alzheimer folks are performing at or below chance because they can't keep up with the pace of these rhythms coming at them. Giant difference. I'll just go with it. With memory, this is the CVLT, which is a list learning task. We read them a list of words over 5 trials. Then we come back and say, okay, read them a second list and say, now tell me the first one again. Now I'm going to tell you the categories. Tell me all the furniture, the food, the means of transportation. That's the cued part. They do great. Look at this. I mean, they're right where they ought to be. They're, between 40 and 50. A T-score, by the way, average is 50. So, but they're right in the sweet spot, pretty where they ought to be. They might have been a little higher in the past, but it's still competitive. I mean, they're doing great with that. When we looked at them in terms of memory on another test, read them stories. They do great. In fact, they retain it quite well. We show them pictures, designs, and they have to draw them and then retain them later. The drawing part wasn't so good. The initial memory wasn't good, but what they got, they hung on to. This is not affecting the part of the brain that Alzheimer's hits, and that's so critical because people want to mix it all together and say, oh, it's Alzheimer's. It's not. All right. Now, higher level reasoning, problem solving. This is where we see a big difference. If average is 50, our group ran about 40 on this. And again, we're comparing these to their statistical norms of groups that we know how they do on the test. We don't have a matched group of people the same age who don't have Parkinson, but that's what the norms are for. And this is not really publishable research. It's just good. It's just a clinical assessment of what we see. But that higher level reasoning, problem solving, that's harder. And people have they're more sluggish in terms of going, oh, I see what's going on here. And that's really the main thing you see. Folks with Alzheimer's do a lot worse than that. And they don't see what's going on, and they can't be prompted out of it. So this is, again, a weak spot, but not like what you get with Alzheimer's. Language. They look good. We show them pictures. What do you call this? What do you call that? And you have to look at line drawings and name them. Folks with Parkinson's do great. Verbal fluency. Tell me all the words you can think of that start with a certain letter. They blow through that fine. Listening to what people say to them and repeating back, that's more dependent on attention, and lo and behold, it's a little bit lower. So again, when you're saying something to your family member with Alzheimer's or with Parkinson's and you don't remember that? Well, did they ever, were the doors open when you said it to them? Which is why it's really important to make sure you have a person's attention. And the person, if you're the person with Parkinson's, you need to be able to say, hey, say that again, that didn't stick. Or I wasn't listening to you, say it, or if you're busy doing something, say, give me a minute. Okay, you want my undivided attention, give me a second. Okay, now, what do you have to tell me? Simple tricks, but that makes a giant difference, and you'll see that it's not memory, it's paying attention, is what's going on there. Academic abilities, reading, spelling, math, stays stable. Alzheimer's, the math goes to really low. Come on, you never know if I push it twice, it's going to go twice. There we go. And motor functioning. Okay, grip strength is not, well, it's low. Doing a pegboard, putting metal pegs in the board. I hate to torture people with Parkinson's doing this, but a lot of these people were DBS, they were being evaluated for DBS candidacy. So I wanted to see if we did this, could we get them back in after DBS and see. But you do see problems. They have to define motor speed and dexterity. no big surprise. It's a big struggle because most people are having manual trimmers. So, what does all this mean? With cognitive, I think there's several things that what this points to. Parkinson's puts more of a load on our brain that's already there. If you're already having aging effects and Parkinson's kicks in, well, it's going to compound that. Does it mean you're going to get demented and end up in happy acres? Probably not. It's not that type of equation. Does it mean you may need more and more help, or you may have more cognitive issues across a long haul? Yeah. How much? Different from losing your identity like you do with Alzheimer's by a long shot. Normal aging. I thought I took that out. It's too much stuff. I think that was probably more for me than for anybody else. Let me go into this. So what are the treatments that work? With Parkinson's, you can try memory-enhancing drugs, things like donepezil or Exelon patch. The doctor I worked with liked the Exelon patch better. She said it worked better with the Parkinson meds. What this does is it increases the amount of dopamine that you have, so the dopamine your cells are making doesn't get broken down and recycled. It hangs around in the gap between nerve cells. When they shoot them out from one side, it connects up to the other side and sends the message on. It's like if you go bowling and every time you knock down 5 pins, it puts another 10 down for you, instead of just putting the other 5 back down. It increases your conductivity. So the memory meds can help. You don't have to have Alzheimer's. It helps better if you don't, to be honest with you. Neuroprotective medication, memantine, some of you may have heard of it or been on it. It's supposed to inhibit the mechanism what causes the amyloid buildup in Alzheimer's. It may or may not be useful with Parkinson's. You just have to try and see if you get a benefit from it. Now, being prescribed these meds, people say, I don't want to take that. It means I got Alzheimer's. Absolutely not. It's kind of like Rogaine. If I used Rogaine, it would be a waste of money. If somebody with a little fuzz on their head tried it, they'd get some results. Women start losing hair, they put Rogaine on, they get a nice thick head of hair. So the more you've got going on, the more you've got preserved, the better you do, certainly with the memory drugs. So that's another thing. With Parkinson's, you're not having a memory decline that is rapidly going down. So the meds may help. It may improve memory. It may improve reliability of memory. Although a lot of what goes on with Parkinson's is attention, not memory. Okay. I'm running out of time, but I'm close. So for DBS, to my knowledge, the literature is showing that DBS is not associated with routine cognitive impairment. It's not so much of a trade-off, particularly since they started going for the inferior global pallidus as opposed to the subthalamic nucleus. Seems to do better. People that actually do the implants may have different opinions about that. But DBS does not seem to have a negative impact on cognition. Some studies show it actually may improve it. Which makes sense. If you're sleeping better, you're functioning better, your brain is more alert, and you don't have to fight tremors all day, you're probably going to have more available resources to think with. I've already done that, okay? I'm so sorry about this. Now, cognitive rehabilitation. When you have something going with your brain that diminishes function, let's say you have a head injury, let's say you have a stroke or something that takes you down where you weren't before. Cognitive rehab can help. What this is it's the same as physical therapy or speech therapy in terms of rebuilding a skill that you can rebuild. Speech therapists do most of the cognitive rehab these days. Psychologists kind of lost out on that race because I don't think we knew that much about it, and when it's number of reasons, but speech therapists do a superb job with it because they're treating not just language, they're treating the whole spectrum of cognitive abilities, most of them that do cognitive rehab. What you're really doing, you can rebuild attention. You can get attention where you can stretch it and make it more better. A person can pay attention longer, better, and process more information at once. That is a buildable skill. You can do muscle building and increase that. Spatial skills, when they worked with older folks whose generally their spatial skills go down compared to younger people, they worked with them, not impaired people, just normal folks, and they got their scores way up again just by practicing, just by working on spatial stuff. So these are things that, would be treatable, and they're things we know that respond well. And executive functioning is one of the things that we always did in cognitive rehab, was get the person's what we call metacognition, their ability to look at their own thinking and get more aware of that and say, oh, this is what I'm doing, this is how my brain's working, this is what I just did that worked, this is what I did that didn't work. I'm anticipating there's a problem coming up, so I do it differently now. That's what training is. The literature is coming up now and saying, time? 5 minutes, okay. Literature more recently is saying it works, and they've done work with Parkinson's, so I don't have to say it could help. It does, which is a good thing. Keep going backwards, I don't get this, okay. Caregiver issues, we had a great talk about that today, I think, but I see this a lot. One of the things between caregiver and the person with Parkinson's is it can put a role change in the relationship, and that's a big deal. First of all, your spouse is your on equal footing. Somebody gets Parkinson's and you have to take on more, and that person's feelings diminished. There's a whole imbalance that can go on in the relationship, and it's tricky. A spouse can resent the other one for taking care of them. It's like, well, I'm trying to help you. Well, don't baby me. Don't tell me I'm forgetting stuff. The why question is the dumbest question you can ask. I agree with him 100%. Why did you forget that? I told you that already. Yeah, well, if I remembered, I wouldn't be forgetting it, right? But that sort of, it's inevitable that stuff can happen because tension occurs, but it changes the relationship, and for the person with it, your sense of who you are changes, obviously, and how you expected life to turn out. For you, the caregiver, I didn't think I'd be doing this at this. I thought we'd be traveling Europe and going on grand, tours of the world, and we're working with this. Well, that's life. It's marriage. That's your commitment. But it's an issue, and I think Dr. Iverson, or Mr. Iverson's point was, you need help is absolutely correct. A little bit of help goes a tremendously long way toward keeping you out of the caregiver role to the point that it compromises your relationship. And if to the extent that you can have your time together in the relationship as your time, that's super important. To the extent to which you have time for you that's not caregiver time, super important. People can get very depressed in a caregiver role, particularly if someone's very involved with Alzheimer's. It's particularly bad because you're losing this person every day. They don't come back. They don't know who you are after a certain point. There's no reward, and people get very depressed with that. With Parkinson's, people hang in there. They're still present. They're still involved. It can be, it changes the activity pattern in your life, but it's different, but still the same principles apply. I would buy his book in a minute if there were any left. So the main thing for caregivers that's important is watch your fatigue. You're going to get tired. You have to pace yourself, and you've got to make sure you got help so you can get rest and respite. You can't do it all yourself. As the person gets more involved, you can't do it all yourself. Isolation. You don't hang around your friends the same way. And depression. Big deal there. My mother's husband had Alzheimer's disease. And she, nice Southern belle, never been depressed a day in her life. That was her motto. I'd never been depressed a day in my life. And then one day she woke up and said, I don't want to get out of bed. And she actually had the presence of mind to say, I think I'm depressed. This is a fault of what I call the no reward lifestyle. You work and work and work, and all you get is diminishing returns. You get depressed. I think with Parkinson's, it's not that same curve, but you got to watch out for the depression. The more you get alone, the more you're isolated, the more you feel like you're not with your spouse anymore. You'll fight with it. So recommendations there. Home care, a little bit goes a long way. If you can get, they usually come 2 half days a week at a minimum. That can work tremendously well. And doesn't have to, that's it from an agency. You might be able to work out other arrangements. Stay active. Get out of the house as caregiver. Depression. Don't hesitate to go get antidepressant medication because you're wearing down and you're going to need. That's going to get you there quicker. And reach out to other people. You're doing that here, and the DAPS, systems that they're setting back up since COVID, has got support for caregivers and for the person with Parkinson's, both. And I think that's super useful. And if you need it, get some supportive psychotherapy, meaning not personality change, just how do you cope with what you got going on and get somebody else's input. Obviously, you're already here to get educated about Parkinson's even more than you already are. Ask the doctor hard questions. Think about what you want to know, and think about what's the issue, and make sure you tell them before you go. Formulate it before you go in, and try to figure out where you can get answers or help. You're here. There's the National Parkinson's APDA. There's a lot of information. Thank God for the internet. It gives us loads of information you wouldn't otherwise have. And I think that's it. So, any questions? I'll be glad to stick around. I'll be glad to stick around too if anybody wants to ask questions. I think I made it close to the clock. Okay.
On behalf of DAPS, we would like to present you with this book. This book of poetry was written by a DAPS member and who's living with Parkinson's. Oh, he's here. Oh, raise your hand. Thank you.
Well, thank you.
Yeah.
Thank you.
Any questions?
Yes. I think the indication for getting baseline testing is you're seeing something change. You have concerns. If you're not having concerns, you can. There's no reason not to, but I think it probably makes more sense to wait until you have a question. That's kind of my take on it, unless you were kind of, just curious and you want to know and you want to have a starting place. I think it's kind of an individual decision on that, but I'm on kind of an as-need basis. Yes?
How long does one of those neuropsychological tests take?
Well, it depends on the person giving the tests. I have a tester in my office who can do a whole day's worth in about 4 hours, and I'm always going, how did you do that? She's been doing it for 35 years, and she's really good most of the time with me, and I'm just, super fortunate. Some people will go real long. Some people will do a shorter battery of tests. I think, my interviews are about 2 hours. The testing's about 4 hours, so it's about 6 hours of data collection, and then you make sure that you're going to somebody who will see you and go over the test results at a later point. What's the point? Doctor needs 2 lines of information. Yes, they have cognitive problems. Okay, thanks. All that work for that? No, you are the client, and make sure that you're the one that comes back in, bring family or whoever you want to know about the same, about the information we gathered, because that's where you get the payoff, is the feedback session. And if you're not getting that, it's not good. I think we're the, okay. Thank you. Thank you all for coming. It's a real pleasure to speak to you.
And Dr. Fulbright, will you be here if anyone has any questions for you? Will you be here?
Yeah, I'll stick around if anybody has questions. Sure.
Please see Dr. Fulbright. We're going to have you back to after.
Really? Well, not for them. I mean, I hope it was worthwhile for them here. I don't know. It's a lot of data to.
This is my card, what I do.
Okay.
I help families find senior living options.
Oh, okay, great.
I don't know if you ever need that.
All the time.
Okay.
Okay, so you're looking for people.
So at my service
You
is
put them
free.
in. You direct them to people, or you provide service.
I
So you're like a
direct
care
them to the
manager.
community, yes.
Okay, great. That's big need,
Yeah,
giant need.
yeah.
So
I started 7 years ago.
it's hard work.